the fact that somebody has problems with disproportionate problems with praxis and perceptual skills is often the giveaway. And Terry Pratchett's experience of being misdiagnosed with a stroke without any good hard evidence of stroke is not atypical. The same way as people with frontotemporal dementias, people with primary progressive aphasia are often diagnosed as having had a stroke because they present with aphasia and everybody immediately thinks, oh, well, that must be due to a stroke. But the giveaway, of course, is the progressive nature of things. The same with posterior cortical atrophy. Your strokes occur suddenly, and if anything, there's some recovery over the first few days and a couple of following weeks and months. Whereas where the problem is due to degenerative disease, it's going to be gradually becoming a bit more of a problem rather than less of a problem. People with the behavioural variant of frontotemporal dementia are often misdiagnosed as having a primary psychiatric condition to explain their sort of odd behaviour. And again, it's often only when somebody gets around to actually perhaps thinking about doing a scan and finding they've got a lot of shrinkage of the frontal lobes that the real diagnosis becomes apparent. Okay, we'll assume that everybody is back. So if everybody puts their hands down and just quickly finish what we're doing, and that's putting the hands down should include me, shouldn't it? So, okay, so if we just go to the next slide. Posterior cortical atrophy, most commonly associated with Alzheimer's pathology. If we come right over to the right-hand side with less common dementias, normal pressure hydrocephalus, there is the other condition that we tend to come across. If we go to the next slide, I think Bijou showed the video of the man walking up and down his garden path before surgery and after surgery, and the clinical presentation of normal pressure hydrocephalus is this triad, these three symptoms. One is of cognitive impairment, dementia, and it's a similar sort of this slow response, lack of spontaneity, what's called a subcortical dementia, the similar one that you get with severe small vessel disease. It's associated with this very wide-based, as if somebody's feet are sort of glued to the floor and they have to sort of pull them off and then slightly stagger forward. And urinary incontinence. So those are the three characteristic symptoms. Now, often obviously lots of people with dementia may have a slightly odd gait, and certainly with advanced dementia, urinary incontinence is all too common. But people presenting with dementia, really the dementia is usually not so severe that it's going to be causing urinary incontinence. So if you're clever, you may sort of be alerted to the diagnosis by the presentation, the symptoms. But more commonly, it's because of the, say, a CT scan report, where you get the picture of hydrocephalus. In other words, the ventricles, the black areas in the middle there, are very, very large. And totally out of proportion to any atrophy. There's very little atrophy of the cortical, the grey cortical tissue there, whereas there is very significant ventricular enlargement, and it will often be the scan report that comes back as saying something like there is significant ventricular enlargement or ventricular megaly that is not an inconsistent or which is out of proportion to the relatively minor degree of cerebral atrophy, and there's no evidence of any space occupying lesion. So have you considered normal pressure hydrocephalus? And you then go back to the presentation, and perhaps you double check again about continence and think about gait and the nature of their dementia, and sometimes the coin will drop that this could be normal pressure hydrocephalus. Sometimes as I say, you can't diagnose dementia and cause the dementia on the scan. So sometimes, yes, the ventricles may be very big and there may not be a lot of atrophy, but when you go back, the clinical presentation isn't consistent with normal pressure hydrocephalus. So it's a clinical diagnosis that is suggested sometimes by imaging. And the important thing about making the diagnosis is that if you find a friendly neurosurgeon who inserts a shunt, a plastic tube into the ventricles and then threads it under the skin down the neck into one of the big vessels above the heart to drain the excess fluid from the ventricles, then the person's cognition may well improve and not deteriorate further. And as we saw in the video, their gait can recover notably. And it's not always that terribly reliable, but traditionally, if one does a before surgery, you do a lumbar puncture and remove quite a lot of cerebral spinal fluid, perhaps 40 or 50 mils of cerebral spinal fluid, and the person significantly improves as far as their cognition or gait for the next couple of hours, then that is supposed to be a confirmatory evidence of normal pressure hydrocephalus and likely response to having an intraventricular shunt. If somebody is not a candidate for neurosurgery or is not keen on having neurosurgery, well, there isn't any point in pursuing this and doing lumbar punctures and things. So before you embark on referring to neurosurgeons and thinking about admitting them for lumbar punctures necessary as a day case, it's always more appropriate to actually think whether surgery is going to be acceptable or appropriate. I say there would be perhaps, if for every 1,000 patients, there would be something like about 10 or 15 reports on scans that query the possibility of normal pressure hydrocephalus, and about half of those, when you go back, you'll think, well, yes, there's enough clinical symptoms here to make the diagnosis likely. But of those sort of 7, 8 patients out of the 1,000, perhaps only 3 or 4 would be appropriate for surgery, and perhaps, well, again, in Cardiff, there would be perhaps 1, 2, 3 people referred to the neurosurgeons a year out of 1,000 or 1,500 patients. But it's important because it's a reversible cause of dementia. So certainly one doesn't want to miss cases that are treatable. Next slide. Now, again, just over on the right-hand side of the slide, as far as less common causes, chronic subdural hematomas have to be considered, but they will be apparent on scans, and it may or may not be appropriate for neurosurgeons to drain them. Huntington's disease, as I think I've said before, I'm not going to discuss because there is a specific service for Huntington's disease in Wales, and the diagnosis is usually pretty clear because unfortunately other members of the family have previously been diagnosed. And then it says rare causes, and next slide. This is a list which doesn't really matter whether you can read or not. There are lots and lots and lots of small print causes. Some used to be very common. Up until the 1920s, 1930s, the commonest cause of dementia was syphilis. But fortunately now, syphilis is sort of very uncommon. In the whole of my career, I only saw, I was going to say 3, it was actually, I only saw 4 cases of dementia associated with syphilis. And in all 4 cases, in fact, I was sort of second, third, fourth opinion rather than actually presenting to me in the first place. In the late 1980s, when HIV AIDS first emerged, AIDS-associated dementia was the second commonest cause of dementia after Alzheimer's disease in some parts of New York and San Francisco. But fortunately, very quickly, things changed, and HIV dementia is now pretty uncommon. And hopefully, we don't know, but hopefully now that there's effective drug treatment to keep viral load down and for countdown, hopefully the significant impairment won't be a long-term sequelae of chronic HIV infection. And then there are lots and lots of others, but as I say, we're not going to talk about them because they're so uncommon. Next slide. I think, in fact, yeah, just the red flags. If when you should have, just have a quick sit down, have a rethink about whether you're getting things right. One is with people presenting with dementia who are young, under 65. They're more likely to have a rare or reversible cause. It's important it's not missed. And I would suggest that people with young onset dementia should probably be seen by people who are particularly skilled in differential diagnosis, either local neurologists or the memory assessment service if they have that responsibility. When there's a rapid decline, you have to think about delirium and tumours, very rapid decline, Creutzfeldt-Jakob disease. And then if there's a focal presentation, so particular language problems, then we should be thinking about frontotemporal dementias, primary progressive aphasia, semantic dementia. If there's disproportionate visuospatial problems, well, posterior cortical atrophy or dementia with Lewy bodies, the characteristic neuropsychological profile, often there's greater visuospatial problems, perhaps less memory problems. Alcoholic dementias and frontal dementias, if social decline, behavioural decline is prominent, and then movement disorders, Lewy body disease, vascular disease, normal pressure hydrocephalus, and so on. So those are the red flag areas. Now, at that point, I'll stop. and we've just got a few things to do. First of all, any questions or queries about anything I've said that anybody wants to raise? If you have, speak now or put your hand up. Otherwise, I've got some very brief summary slides that I'll just quickly go through. Will only take 2 or 3 minutes. But before we do that, I think, can I hand over to you, Michaela, for what we do now.
What we do next.
Yep.
Lovely. Do you want to do your slides, or do you want me to do
Yep.
my bit, and I'll finish off rather than interrupting your slides?
Yeah. Okay.
Yeah.
Well, the slides, here we are. They're here, so we can. And these slides, if you're going to sort of print out anything and have it on your desk or whatever, these are the slides that I'd suggest you think about printing out or having good there. One is the summary slide, so that really you just, if you're presented with a patient, you approach them logically. Your step one is, what's the syndrome, and which box do they fit in? And then step two, if they have a dementia, what's the likely predominant pathology? Bearing in mind that without the use of biomarkers, at the moment, guessing what the subtype is actually going to be wrong, perhaps 20–30% of the time. With biomarkers about to emerge, that's going to change. And then the next slide, if we're things to think about when we're getting a history, and again, you can potentially use this to sort of refresh your memory or check that you've covered everything. The next slide is things we need to do about the assessment, and there's more to it than just bashing through an ACE. So thinking about vision, hearing, putting things into context, thinking about whether the ACE is appropriate given the person, for example, for people with low literacy or non-European cultural backgrounds, the RUDAS may be more appropriate. Whether it's appropriate to have use some sort of formal assessment of mood, like geriatric depression scale, or collecting functional assessment, blood tests, imaging, and then next slide, then getting to the stage of, well, what's the diagnosis? And the most important thing is to get all the evidence before you start reaching diagnosis. You don't need to do a PET scan or a full neuropsychological assessment or refer to an OT or speech and language therapist in the vast majority of patients. But in a small minority, it might help. And you need to actually think, first of all, whether it is or is not dementia. Are there any red flags? And then if it's dementia, what's the subtype? Importantly, down the bottom right-hand corner there, you then need to assign the appropriate read code, because that is the only way that that people with dementia can be tracked or picked up or counted or identified. So it really is pretty critical. Next slide. You then have to tell them the diagnosis, which I think is largely a matter of observing people who do it well. When it's when it doesn't go so well, think why. And there are basic things, making sure that you've got enough time, giving the person the opportunity to actually be relaxed and think how much knowledge they already have, what they're expecting. Don't blurt the whole diagnosis out. in one go. There's giving it in small chunks is good practice, with a sort of warning shot about whether bad news is coming. Importantly, it's always worth spending some time on distinguishing dementia from the subtype of dementia, because I'm sure we're all used to the commonest question that's always asked, well, is it dementia or is it Alzheimer's? Because one doctor said it was dementia and now you're telling me it's Alzheimer's. And which is it? You don't seem to know what you're talking about, because people don't understand the difference. So certainly I find actually using scan pictures, having a scan on the screen to illustrate, there is shrinkage in this area, or here is the brain, and that area is seems to be damaged. People seem to accept black and white pictures much more than they just accept my word for it. They don't know what the black and white pictures mean, and they're quite happy to accept my interpretation. That's perhaps useful, and then allow lots of time for questions, and importantly summarize, or even better still, ask the person to summarize at the end of the discussion, with leaving it there, being honest, but trying to put things as a glass half full rather than the glass half empty. So being positive. And then next slide is what can we do about it? And here's a thing, sort of checklist for things we should be thinking about for an increasing number of people with a diagnosis of MCI. Yes, we should be thinking about controlling their vascular risk factors. Importantly, although the evidence that actually is going to slow cognitive impairment isn't quite so strong, but certainly healthy behaviours, and then memory strategies and vision, and where it's appropriate, driving safety. And then the last slide, which is difficult to get all on one slide, but thinking about the things we should be doing for somebody with a new diagnosis of dementia. And obviously, if somebody doesn't drive, well, we don't have to discuss that. But not everybody's going to be suitable or want anti-dementia drugs, and so on. But certainly those are the areas that we need to actually consider, and not just discuss, but also provide good quality written information and in print, and recommending trustworthy websites. And the two trustworthy websites are probably the Alzheimer's Society here in the UK, and the Alzheimer's Association in America has a very good website, although obviously it's relevant to American services. The problem with the Alzheimer's Society website in the UK is that it has almost too much information, and it's quite hard for people to navigate. It takes me a long time to, I know what I'm looking for on it, and it always takes me sort of a lot of taps of the mouse to actually find it. So that's a disadvantage of the website. So those are the summary of everything that you can use for references. So having said that, I will now definitely hand over to Michaela to have the last word.
Oh, thank you, Tony. I'm sure we all want to thank Tony for his wonderful sessions and learning that he's given us all over this last 4 days. So, and all the other speakers as well, but Tony's sort of the linchpin. So thank you, Tony. Every round of applause, everyone, for Tony.
Pleasure.
Thank you very much. Right, so we've come to the end of the 4 days, and also I'd like to thank Tara and Sue that have helped us in the background, put all the slides together and do the sort of sorting out of all the tech stuff. But going forward, obviously this is your last day, your cohort 4. What we're going to be planning for you is a follow-up day, and it's likely to be not too far away. We're going to try it for probably towards the end of January. But what we need from you, we're going to be giving you evaluation forms, obviously, for this 4 days. You also get a certificate, but what we really need from you is a heads up, and we'll put something out so that you can communicate with us on what you need on that follow-up online session. It's not a day, it'll be probably an hour and a half, 2 hours, so that we can just follow up on some of the learning that you've had in this 4 days, pick up some questions that you want to sort of ask or clarify, things you want to clarify, things you know you need to know a little bit more about. And that's actually a key as well. What is it you need to know more about? What you're not as comfortable with, and you'd like some more information. And also on that session, we'll be able to sort of firm up where you've managed to get to regarding working with your mentor and doing your observations as well. So we'll give you that date. It'll come out to you via us, and we'll also give you a little bit of a communication template that we can sort of find out some things that have been happening in your practice that you've been able to get on with or not get on with, and what you want more of from the faculty in the follow-up sessions. So we'll do that in January, and then we'll try for ongoing drop-in sessions. We've done that with all the other cohorts where they've been able to bring specific cases. I think we'll probably join you in with other cohorts. We'll reconvene that, Tony. I think we were thinking about reconvening that for all of the cohorts. So you'll have a drop-in session that you could bring some cases, you can talk through some cases, and Tony and others, and myself, will be able to talk you through some of those things. So that's what's going to happen next. The faculty itself, we've got a meeting early in January to decide and plan for what's going to happen to the faculty, and what kind of events and come-togethers, I suppose, and masterclasses that we're going to plan for over this next year. We've reconvened this work with you as faculty, cohort 4, but we do have the other 3 cohorts that are making up the faculty, plus wider clinicians that are part of the faculty. So we'll do some planning, see what that looked like, put some master classes in, and we also want to plan for an event where we all come together, the 4 cohorts, and sort of do some showcase work and that kind of thing. So we'll keep you abreast of all of that information as well. Now, one of the other requirements of being part of the dementia diagnosis course in the faculty is that you undertake some QI work, so quality improvement work. So that if you remember back to your application and everything, it talked about the quality improvement and doing some small little initiatives, or one initiative to take forward an idea that you have for your own practice and then share that. So our Academy in Improvement Cymru have one day, they have a 1-day fundamentals training. So they have some dates. The first one is in January, but they're staggered. If I share those dates with you, rather than us trying to get all of you back together, it may be just as wise that you try to book on one of those days. That's what we've done for the other cohorts. They were able at that stage to do it as one cohort, but they don't have the capacity to do that now. So they're asking you to join those dates. This would be important if there are people on this cohort 4, that haven't got a lot of confidence around quality improvement methodologies to support you to sort of look at some initiatives. But also, if you have done quality improvement before, it might be just as wise to touch base and have it as a bit of a refresher. They're really lovely courses, and they're not heavy, so they're good either way, really. So we'll provide you with the dates for those, and I'll put all of this in sort of the chat after the call is finished, because it's easier to type it all in and you'll see it all, and we'll send it all around by email as well. Now, the other ask is they also have a 4-day, they call it improvement in practice, where they'll take you through actually your idea for a project. So you might use your first day with them to actually think about the kind of initiative you want to do as a project, a quality improvement project. And then when you're ready to take it forward, they'll actually work with you and coach you and take you through the methodologies needed to get that project into sort of place. So that's another offer that they've given us, that there's a 4-day quality improvement that you could actually do the whole of your project with that support and them supporting you to do it. So we'll put that in there as well. Other than that, I'm sort of thinking as well, how do we find out? So I've already spoken about the follow-up day, and yeah, we'll send out a template that looks at whether you've been able to meet with your mentor. You know, the usual things that we've spoken about when you've come on the beginning of the days. Have you met in with your mentor? Have you done observations? Have you delivered a diagnosis and been supported with that? So we want to touch base with you about those things as well, because they're really fundamental to what this course has been, you know, sort of supporting with you to be able to take forward your practice. And we'll bring those, we'll sort of get a template out so that we can gather that information for you as well. So other than that, I've talked about the evaluation forms. Please, can you complete them, because we can't shape this 4 days without knowing that it's given you what you need, and knowing perhaps what else we could be doing for you. So please give your feedback to us, because it's really important for us to shape for future cohorts. And then obviously the certificates will come out to you as well for you completing the 4 days. So I hope you've enjoyed it. I hope you've learned an awful lot from it. And my last thing is, please make sure that you have a pathway in your team for putting read codes down on the documentation. And I'll hand you back to Tony. Thank you, everyone.
Well, thank you, Michaela. Yeah, I think Michaela's I think only gets paid each month if read codes are recorded. So it really is important for her. But more important, as I say, it is the only way that one can possibly sort of track what's going on. And you know, we're familiar with, you know, the rhetoric that how Wales, you know, record is so poor as far as dementia numbers and diagnosis compared with England, Scotland and national Northern Ireland. And part of that reason is because they have, I think, more robust ways of counting the numbers, whereas up until sort of recently, Wales hasn't. So the read code is also a method to actually counter that argument as well.
Yeah, one of the requirements I would just say, Tony, sorry to jump in, is that your service needs to have a pathway in place, so that there is a pathway for how those read codes get back to the GP. So I suppose it's about you going back and checking with your service that you've got that pathway in place and that it's working.
And by
might need to be reviewed.
Who's responsible for telling the GP?
Yeah, what to do with those read codes, what, you know, what happens as soon as a diagnosis is made, where you put that read code, who sends it back to the GP, how it gets onto every part of the communication, like letters and things like that. So that should all be in your pathway on how that happens.
And I think the answer is it's everybody's responsibility. Really, it's easy, and including, most importantly, you know, medical secretaries or anybody who's actually processing the information. Very much they're involved. I'd very much echo the importance of the sort of feedback evaluation form. I know at the end of these things there's always an evaluation form, and it's a bit of a drag to actually have to think of something to say, but it really is useful just to know what works, what doesn't, and how to pitch it. And the advantage is, if we get that evaluation form from you, well, then you'll get a certificate certificate back. So that's a good reason to do it. And then also importantly, on that, thinking what's going to be useful for you in the next year, because we don't want to organise things that are just a talking shop or a waste of people's time. So what would be really useful for you? So with that, unless anybody has anything more to say, I'm sorry we've run over by my clock by 1 minute, but that's pretty good for these sort of things. And I guess go forth and diagnose, and let's hope that we can improve the both the diagnosis and the assessment and the management of people across Wales. So thank you very much.
Yeah, thank you all. Well done, because you've really taken on a lot of information here in this 4 days. So well done, everyone.
Thank you. Thanks very much.
Obviously, all the slides are on the Padlet. So if you want to actually just refresh your mind and knock through those, you've got access to them there. And thanks very much, Tara, for doing all that as well.
Yeah.
With that, enough thanks.
Merry Christmas.
And
Merry Christmas, everybody.
Yep.
Bye.
And keep warm.
And keep warm. Take care, everyone.
Thank you. Bye.
You've had applause there from Lisa, Tony.
Excellent. How do you know it was for me?
Oh, I don't know. It's just applause. Well, you're the one that's holding it all together, aren't you? You've got to give due respect.
Absolutely.
To the expert here.
Well,
great. Thank you.
Thank you, Lisa.
Bye. Bye-bye.
Bye.
Bye-bye.